Thank you so much. It's wonderful to be here, and thank you for those of you that have stayed to listen to this session. Here are my conflicts of interest. So as we've heard many times at this meeting, we have 38.4 million people living with HIV in 2021, 75% of adults and 52% of children having access to and being on treatment. And it's really important to say that in order to get to zero, we're going to need to have modalities that are acceptable and possible for everybody to take. And this is where long-acting therapy comes in. And at the moment, the indication for long-acting therapy is for those who are switching while undetectable. So as we know, and we've heard from several different sessions, we now have cabotegravir rilpivirine. It's a 2-drug complete regimen dosed 2 monthly. And given in this way, it amounts to 6 treatments per year. And what we see is that it's come into international guidelines, in the European guidelines, the DHHS guidelines, the IAS guidelines. However, it is not universally available, and this is a very important point and a very important concern. So in terms of efficacy, I'm not going to belabor the point in terms of what we already know prior to this meeting. We know that non-inferiority has been confirmed for the Q8 and Q4 arms out to week 152 in the Atlas 2M study, which compared 4-weekly to 8-weekly cabotegravir rilpivirine. So what I'm going to do for the remainder of the talk is I'm going to cover the real-time coverage from this meeting and talk about what's been presented and what it means. So at this meeting, the Carousel study has been presented. This trial is an implementation study which is being conducted in 5 countries in Europe with 430 participants. Here I'm showing you the virological response at month 12. You can see 87% of people with virological success and a 0.7% of people experiencing confirmed virological failure. So successful in a less regimented trial than a phase 3 trial, which is good news in terms of this regimen. So I'm going to give you some thoughts on confirmed virological failure and resistance, because this is a very important topic when it comes to this combination. So I'll start by looking at confirmed virological failure at week 48 and beyond, how we can try to predict and work out who may experience confirmed virological failure, and then talk about treatment after virological failure, should this happen. So at week 48, across the phase 3 trial program, what we saw is that the confirmed virological failure rate was 1%, and the resistance, when it occurred mainly to 2 classes of drugs, with the mutations that I've listed on the slide. What was done in order to try and understand how to predict when this may happen was a multivariable analysis. And what was identified is that there are 4 important factors, 3 of which can be identified at baseline. They are baseline rilpivirine resistant associated mutations, which is the strongest predictive factor, the A6A1 subtype, the BMI greater than 30, and then something that can't be predicted at baseline, the week 8 rilpivirine trough concentration. And what's been shown is that the most powerful predictive model is when you have 2 or more predictive factors. So in terms of the Atlas 2M at 152 weeks, let's think about this in terms of this model. So what we saw is that 13 out of 1,045 people experienced confirmed virological failure, 11 of whom were in the Q8 arm, 2 of whom in the Q4 arm. All of these participants received their injections on time within the 7-day window. 10 of the confirmed virological failure events occurred by week 48, and 6 of these had more than 2 baseline factors. 2 of these events occurred beyond week 96 without 2 or more baseline factors. So let's move to the Carousel study and confirmed virological failure reporting. So through week 48 of the study, of the 430 participants, 1 participant developed confirmed virological failure. This participant developed 2-class resistance, and what we saw is that rilpivirine RAMs were present at baseline, and the BMI was on the border, it was 29. There was another participant who had suspected virological failure who developed NNRTI resistance only and had a baseline factor of a high BMI. Both received injections on time. So if we look at this visual, which shows you the timing of confirmed virological failure across the phase 3 trial program, what we see is that the preponderance of virological failure events occur prior to week 48, with very sparse numbers of events occurring distal to week 48. And this is helpful as a clinician in terms of what we can say to our patients who are going on to this combination. In terms of resuppression post-confirmed virological failure, what is known is that in the FLAIR study, 4 of the 5 participants were resuppressed on a subsequent regimen, and in the Atlas 2M study, 12 out of 13. The remaining 2 were finding difficulties with adherence, and this was at the heart of the lack of resuppression. Considering the use of the oral lead-in, in terms of the FLAIR week 124 study, what happened in this trial is that those participants who originally received the oral comparator were given the opportunity to move over to long-acting cabotegravir pivirine at the week 96 time point. They were given a further choice, together with their doctor, to select whether or not they chose to go forward with or without the oral lead-in. This was because the FDA allowed this choice to happen because of the relative absence of any events of concern during the oral lead-in period across the phase 3 program. And what you can see here is that the efficacy outcomes were almost identical, and the pharmacokinetic properties were also very similar. At this meeting, there's some data from the SOLAR study concerning the oral lead-in usage. The SOLAR study is a study comparing bictegravir FTC and TAF to cabotegravir pivirine long-acting. And what this study reported on was a survey for 111 healthcare professionals in 13 countries. They evaluated why the healthcare professionals opted for or against the use of the oral lead-in. What they found is that 53% of the investigators preferred to go straight to injection, but 32% preferred to continue the oral lead-in. There were regional differences, and there were differences with sites with more patients preferring to go straight to inject, and those who were comfortable with the safety profile were happy to go straight to inject. But investigators had already done trials which had used an oral lead-in, preferred to stick with the oral lead-in. So that's the first readout from the SOLAR study. In terms of safety, at week 152 of the Atlas 2M study, no new safety signals have arisen. The most commonest non-injection site adverse events are pyrexia and fatigue. There was a 1% adverse event withdrawal rate in the Q8 arm, and 2% discontinued due to ISRs by week 152. Within the SMPC, which we now have, there are 4 things listed in terms of serious potential adverse events. They are hepatotoxicity, pancreatitis, cellulitis, and post-injection reaction. These are all very, very uncommon events. So implementation, who, where, and how shall we include? At CROI 2022, we saw an interim analysis from the MOCA study, which enrolled adolescent participants. This is a very important potential population. What was seen in this interim analysis is that cabotegravir pivirine in adolescents achieved similar exposure to adults. There were no new safety concerns, and adolescents and parents both found it highly acceptable. Obviously, we're still waiting for the efficacy readouts in this trial. At this meeting, we saw the data, the first readout from the CARLOS study. The CARLOS study is a study which is held in Germany. It's considered to be a real-world study of 236 participants from 18 sites. 95% of these participants were male, 75% are under the age of 50, and the ethnicity was not described in this abstract. What I'm going to show you here is the suitability for cabotegravir pivirine from the perspective of the healthcare provider. And what you see is the most common patient characteristics considered as important for suitability for long-acting therapy, and people were able to select multiple responses. And these things were people who are tired of taking pills every day, people who feel experiencing stigma or stress or anxiety over daily adherence, or concerns about disclosure. Rather concerningly to me, The fifth most common reason that someone may be considered suitable for long-acting therapy in this trial was being male. So moving towards inclusion, I always try to end all of my talks on the topic of inclusion. When implementing long-acting cabotegravir or pivarine, it's not only important to move out to other settings beyond the resource-rich world, but it's also important to ensure that this is a therapy that is for everybody. So in the UK, we are doing a multi-site study, which I'm leading. It's an implementation study, and the study will be assessing where to give the therapy. The first 6 months will be given in the clinic, and the second 6 months will be given in the community at a site chosen by the investigators. This study adopts a proactive approach. It's an anti-racist, anti-sexist, and anti-ageist study design. We will be capping white participant enrollment, we will be capping male participant enrollment at 50%, and we will be capping the enrollment of people under the age of 50. And thank you. And we'll be doing our absolute best to ensure that we actually achieve these targets. It's absolutely important that we move from grandstanding and talking about inclusion to actually adopting a very proactive and hardline approach. We'll also be doing the No-LANA sub-study, which is about understanding the reasons for non-participation in this trial for people who chose to go forward and take cabotegravir or pivarine within the NHS. And I think it is vitally important that we start to gather data on participants who don't come from the traditional categories. So with that, I'm going to end and hand over to the next speaker. Thank you for your attention.